Welcome to my channel. In this video, I will talk about small cell lung cancer, or SCLC. Small cell lung cancer is a highly malignant tumor that typically presents centrally in the major bronchi. It accounts for 15% of primary lung cancer and is associated with male and smokers. Small cell carcinoma is strongly associated with smoking. Only 1% of cases occur in non-smokers. So if you see a question about a lung cancer in a non-smoker, it's likely not SCLC. The most common somatic driver mutations associated with small cell lung cancer are amplification of L-MYC oncogenes and loss of function of the tumor suppressor genes such as P53 and RB. Small cell lung carcinoma is an aggressive, poorly differentiated, and high-grade tumor. By the time it's diagnosed, the cancer has often already metastasized, so surgery usually isn't an option. Treatment is chemotherapy, sometimes paired with radiation. Let's talk about histopathology of SCLC. When you look at SCLC under the microscope, you notice that the tumor is made up of small, dark blue cells that are roughly twice the size of lymphocytes. These cells are blue because they are basophilic. They are round or oval cells with small amounts of cytoplasm, i.e. high nuclear to cytoplasmic ratio, and a hyperchromatic nuclei that is dispersed in salt and pepper pattern. Small cell carcinoma arises from neuroendocrine cells, Kolchitsky cells, of the bronchial epithelium. Under an electron microscope, these cells show dense core neurosecretory granules. These secretory granules are also found in other neuroendocrine tumors. So due to these granules, tumor cells of SCLC stain positive for neuroendocrine tumor markers such as chromogranin A, neuron-specific enolase, synaptophysin, and CD56, neural cell adhesion molecule. Clinically, the symptoms of SCLC come from both the tumor's local invasion and its early metastasis, giving rise to cough, dyspnea, hemoptysis, or bloody sputum, wheezing, and chest pain. SCLC can also present with symptoms due to associated paraneoplastic syndromes. Cells of small cell lung cancer can produce a number of polypeptide hormones, including ACTH and ADH. So small cell lung cancer is also associated with neurologic and endocrine paraneoplastic syndromes, including SIADH, Cushing syndrome, Lambert-Eaton syndrome, and subacute cerebellar degeneration. Of these, the most common paraneoplastic syndrome-associated small cell lung cancer is SIADH. A handy mnemonic for these paraneoplastic syndromes is SCLC, S for SIADH, C for Cushing syndrome, L for Lambert-Eaton syndrome, and C for cerebellar degeneration. SIH. Let's start with syndrome of inappropriate antidiuretic hormone secretion, or SIADH. Small cell lung cancer is the most common cause of SIADH. In SCLC, the tumor cells ectopically produce ADH. This high ADH secretion leads to increased water reabsorption in the renal collecting ducts. This free water retention dilutes the sodium level in the blood, resulting in hyponatremia and decreased serum osmolality, i.e. hypotonic hyponatremia. On the other hand, less water is eliminated into urine, resulting in inappropriately elevated urine osmolality and high urine sodium. This production of concentrated urine is inappropriate. The kidney should have diluted the urine to remove excess free water from the body. But the kidney is doing this due to the inappropriately high levels of ADH released by the tumor. So what do you see in the lab in SIADH? You will find hypotonic hyponatremia with increased urine osmolarity and urine sodium. Clinically, patients with SIADH presents with fatigue, anorexia, nausea, vomiting, lethargy, confusion, and seizure. On physical exam, these patients generally appear euvolemic, meaning they don't have signs of fluid overload like swelling or distended neck veins, despite the water retention. Fluid restriction and table salt are the best initial treatment of mild SIADH. The hyponatremia will resolve within weeks of starting chemotherapy. Other treatments may include dimeclocycline, 3% hypertonic saline. To put this into context, here is a vignette. A 64-year-old man with 30-pack-year smoking history presents with cough, dyspnea, hemoptysis, wheezing, weight loss. His labs show serum sodium level of 123 milliequivalent per liter, and his chest X-ray shows a 3 centimeters mass in the left hilar region. If you were to biopsy that mass, what will be the most likely histology type? Small cell lung cancer would be the most likely diagnosis, given its strong link with SIADH. Cushing syndrome. Small cell lung cancer can also sometimes cause Cushing syndrome due to ectopic secretion of ACTH. This results in increased cortisol release from the zona fasciculata of the adrenal cortex. This extra cortisol leads to a host of problems such as hypertension, hyperlipidemia, hyperglycemia, hirsutism, osteoporosis, easy bruising, striae, hyperpigmentation, weight gain, and fat redistribution, i.e. truncal obesity with wasting of extremities, round moon, facies, and buffalo hump. Neurologic paraneoplastic syndromes. In some patients with SCLC, proteins made by tumor cells can trigger the immune system to produce autoantibodies that bind to SCLC cells and cross-react with similar protein present in neurons of the central nervous system or the neuromuscular junction. This is a type 2 hypersensitivity reaction. These autoantibodies, anti-neurons, can lead to several neurological issues such as paraneoplastic myelitis, encephalitis, subacute cerebellar degeneration, and Lambert-Eaton myasthenic syndrome. In Lambert-Eaton myasthenic syndrome, the autoantibodies target the voltage-gated calcium channels on the presynaptic membrane at the neuromuscular junction. Under normal conditions, these channels allow calcium to flow in when an electrical impulse arrives, which then triggers the release of acetylcholine, the neurotransmitter that tells your muscles to contract. In Lambert-Eaton, the autoantibodies bind to calcium channels and less calcium enters the nerve terminal, so less acetylcholine is released. As a result, the muscles don't get the signal to contract properly, leading to proximal muscle weakness, for example in the legs, dry mouth, and constipation. Interestingly, in LEMS, the muscle weakness improves with more exercise, a clue that helps distinguish it from myasthenia gravis. Thank you for watching this clinical overview. If you found the video helpful, please like, share, and subscribe, and don't forget to leave your comments below. Until next time, happy studying and good luck.